Hello again. This is going to be a talk on the tachyarrhythmias. So we're talking about 4 different kinds of arrhythmias, 4 different classes. This is just my way of classifying them. You can classify them however you want, but I think personally think this is the best way to think of them. We're talking about the bradyarrhythmias, which is arrhythmias which are slower than 60 beats per minute in adult. Tachyarrhythmias, which are greater than 100, the flutters and fibrillations, and then premature contractions and pre-excitations. So tachyarrhythmias, what I want to disclaim here is that we're just going to assume that in all of these tachyarrhythmias that the patient has a pulse. Now there are tachyarrhythmias where in any of these really, the patient might not have a pulse. That's going to change everything. And we're going to talk about tachyarrhythmias or tachycardia without pulse in a different section. But here we're assuming that the patient has a pulse. So that's always something you need to check in any patient that comes into the ED or any patient with chest pain, or if they've lost consciousness, check their pulse. It's always a good first step. Usually the nurse will do that though. All right. So tachyarrhythmias, by definition, they have to have a heart rate of greater than 100, and the symptoms here are going to be very similar to what you see in the bradyarrhythmias, but they're usually going to include palpitations, and the palpitations is just the sensation of the heart moving inside of the chest. So you get palpitations because you feel the heart moving inside the chest, and then you have the lightheadedness, dizziness, and possibly syncope, because some tachyarrhythmias may result in decreased perfusion. So your first step in any patient that comes in with palpitations, lightheadedness, and you usually don't have to actually check it, but in any patient you want to look for stability. So is the patient conscious? Are their hemodynamics good? Does this patient have a high blood pressure, a normal blood pressure, or a low blood pressure? Does the patient have a pulse? Is this patient stable? If the patient's unstable, then in any tachyarrhythmia, you're going to go ahead and sedate if you have the time. And generally you'll use benzodiazepines, IV, and cardiovert them. And you're not going to want to waste any time. And what cardioversion is it's just synchronized defibrillation. So that's a rule. If a patient is unstable, we're going to prefer cardioversion. But in most patients, they're going to be stable. And so we're going to want to try some kind of medical therapy. All arrhythmias are diagnosed on EKG, so we're going to want to have an EKG. Now think about it, you have a patient who has a heart rate of 100, they say they have palpitations, and they've got other symptoms. EKG is an obvious next step, because we want to know what's going on with the heart. And EKG is really our way of seeing how is the heart working, how is the heart functioning as far as its conduction. And another general rule is any patient who is experiencing acute symptoms, palpitation, lightheadedness, dizziness, syncope even, should receive some kind of therapy. So there are tachycardias that we don't treat, but if there are symptoms with the tachycardia, generally we're going to give them some kind of therapy. So we're going to talk about sinus tachycardia. We're going to talk about the narrow QRS complex tachycardias. By narrow QRS, I mean the time from the Q point to the S point is less than 0.12 seconds. We're going to talk about the wide QRS complex tachycardias, and there's 5 that make up these 2 categories. And they've got pretty distinctive EKGs. So if you remember what the EKGs look like, you're golden. They all present pretty similarly, though. So first off, let's talk about sinus tachycardia. Sinus tachycardia, like sinus bradycardia on the opposite end, is an elevated heart rate as opposed to bradycardia being a low heart rate. But otherwise, this patient on EKG has a normal sinus rhythm. They've got normal PR intervals. They've got a QRS complex after every P wave. They got a T wave indicating atrial repolarization. Everything is fine on their EKG, other than they've got a heart rate greater than 100. And this can be due to so many different things, and usually it's inconsequential. I mean, I was watching a hockey game earlier. I probably had sinus tachycardia because I was getting a little upset. So lots of normal things can cause this. There's also abnormal things that can cause this. So Any patient, though, that has an elevated heart rate and they have symptoms, we should get an EKG. We should do a workup because it's troubling to the patient, and we're associating symptoms with an elevated heart rate on our physical exam. So EKGs are generally a good idea as part of our initial workup. Usually the cause is going to be clear on your physical exam, so if the patient is in pain or if they're nervous, that's a common cause of tachycardia, and it's going to be sinus tachycardia because there's nothing wrong with the heart in those cases. Dehydration can cause sinus tachycardia. The heart rate has to speed up to keep the blood pressure up. Panic can be a cause of sinus tachycardia, kind of like me during the hockey game. Sinus tachycardia can be an effect of drugs, so stimulants, cocaine, those can cause sinus tachycardia as well. They can also cause other tachycardias, but sinus tachycardia would probably be the most common. And then there can be causes that are hormonal. Hyperthyroidism is a big cause of sinus tachycardia, so if you have a patient that's gaunt and thin and they've got bulging out eyes and they have had weight loss, then sinus tachycardia or hyperthyroidism is probably the cause of their tachycardia. If the patient has a high blood pressure with their tachycardia, pheochromocytoma is a possibility. And then anemia will speed up the heart too. So your physical exam is going to be really important to sort of hone in on what the cause is. But on EKG, you should know what sinus tachycardia looks like, and I'm going to show you that. So here we have it, a normal EKG. It's just a little fast. So you should remember how to count the rate by the boxes. Usually a normal, the lower limit of normal is 5 boxes between QRS complexes. So if there was one big box separating QRS complex, that would be 300. 2 would be 150. 3 would be 100. So if there's less than 3 boxes, big boxes between QRS complexes, then you know that the patient has tachycardia. And if there's more than 5 big boxes in between QRS complexes, you know the patient has bradycardia, less than 60. So here we have about 2.5 big boxes between each QRS complex. So this patient is hovering somewhere between 100 and 150, probably about 130 beats per minute. So this is tachycardia. But look, we have a P wave here, normal QRS complex, normal T wave here. Nothing abnormal about this EKG other than that their heart is a little fast. So this is sinus tachycardia. Here's another one. This is even a little bit slower than the last one. This is probably about 120. You got well, no, it's about the same. You got about 2.5 here, so it's probably about 130, 140 beats per minute. Either way, it's tachycardic. It's less than 3 big boxes between each QRS complex. Here's another one. This one's also 2.5. Okay, I didn't do that on purpose. So again, about 130, 140 beats per minute. So for sinus tachycardia, the reason that it's really important to know your physical exam, to know the different causes, is because for sinus tachycardia, we treat the underlying cause. Sinus tachycardia itself generally is not problematic. It can be problematic in patients who have coronary artery disease because it increases the oxygen demand. And that's why we give beta blockers to patients who have had a heart attack or who are at risk for heart attack, because that's how it decreases the oxygen demand, as it slows the heart rate down. But for patients with sinus tachycardia, if we know the cause, we treat the underlying cause. We don't need pharmacotherapy other than to treat the underlying cause. So paroxysmal supraventricular tachycardia, PSVT. That's a mouthful. So what this is it's an ectopic stimulation of the ventricles originating somewhere in the atria besides the SA node. Now, that's a general term for supraventricular tachycardia, and I want to make it very clear what the difference is. So we're going to go here first. So what is supraventricular tachycardia versus paroxysmal supraventricular tachycardia? So supraventricular tachycardia, let's envision, if you go back to M2 year, and envision how, actually probably M1 year, and envision how does the heart conduct. You have your SA node, your sinoatrial node, sitting right about where your superior vena cava meets your right atrium. That conducts through the atria, and you get atrial depolarization. The atria are contracting. That causes your P wave. Then that electricity gets to the AV node. The AV node causes electricity then to go through the ventricles. That causes the ventricles to contract. That causes your QRS complex. And after your ventricles have contracted, your ventricles repolarize. And so then you're getting your T wave. So what SVT is, supraventricular tachycardia, is it's any kind of arrhythmia that causes information or impulse or electrical activity to go to the SA node, go to the AV node that's not the SA node. So you're getting input from somewhere else. Normally you're supposed to just go SA node, AV node, and then through the ventricles. But with any kind of supraventricular tachycardia, you have an input competing with the SA node to the AV node. And because of that, and because the SA node always goes 100 beats per minute and can be lowered based on, or raised based on the circumstances, but it generally stays pretty regular, if you get stimulation from somewhere else, somewhere other than the SA node, then you can get a tachycardia, because you're getting input to the AV node, which are going to tell the ventricles to contract, which is going to cause your QRS complexes, and it could be 190 beats per minute. It could be 400 beats per minute. It doesn't really even matter. You're getting ectopic stimulation to the AV node, and it's not the SA node. It's somewhere in the atria, somewhere on the atria. And so we call it supraventricular because it's not in the ventricle. We'll talk about something that comes from the ventricle, but these are coming from above the ventricle. So supraventricular tachycardia. And what they all have in common, what all supraventricular tachycardias have, this whole class of tachycardias have in common, is that you're getting an ectopic stimulation from somewhere other than the SA node. And it's going to the AV node, and it's causing a tachycardia. Now, on the other hand, paroxysmal supraventricular tachycardia is basically defined by this term here, paroxysmal. These patients can be totally normal, and then they just go into these bouts of general old supraventricular tachycardia, where they're getting some little bit of tissue somewhere on their atria that is conducting to the AV node. And it's usually very close to the AV node. Actually, it's always very close to the AV node with paroxysmal supraventricular tachycardia. So you've got SA node input to the AV node, and you've got this ectopic input to the AV node. And what happens is the ectopic input to the AV node overrides the SA node input to the AV node. And so you get this tachycardia. And you basically get this loop, because the ventricles will depolarize, and that could actually stimulate that ectopic tissue, which then stimulates the AV node, and that can just go back and forth and back and forth. So what happens in these patients is that they get a supraventricular tachycardia, all the features on EKG of supraventricular tachycardia, but they happen in bouts. They happen in episodes. It's not all the time, and it's idiopathic. We don't know why it happens. We can't link it to a cause. And so the symptoms of this are going to be palpitations like in any tachycardia, and possibly dizziness and shortness of breath. These patients on EKG, when you look at their EKG, you're going to see a QRS complex, but you're not going to see any P waves. Now, there are P waves going on. They do have atrial depolarization from their SA node, but they're having so many QRS complexes because of that ectopic stimulation that the P wave just kind of gets molded right into the QRS complex. It just kind of blends right in. And the only other thing we see other than the QRS complex is the repolarization of the ventricles, which of course has to happen before we get another depolarization of the ventricles. So we're going to diagnose this on EKG, and this can be a wide age range. So anytime a patient comes in and they have palpitations, or they have palpitations and dizziness or shortness of breath, and especially if they're young, we're going to get an EKG. So here is what I'm talking about, an EKG. Look at how fast this heart is beating. There's only about two big boxes separating them, so you're getting about 150 beats per minute. And if you go down to V6 here, go down to this long strip, all you're seeing are QRS complexes and then T waves. You're seeing ventricular depolarization and ventricular repolarization. Yes, you do have P waves, you do have atrial depolarization, but because the heart is beating so darn fast, you can't see your P wave. It's just kind of getting absorbed right into your QRS complex. And I'll show you another EKG where you can see that better, is right here. So here you can kind of see your P wave, and you definitely can see your T wave right here, although it's not really accentuated too much. But here you have it again, where your P wave is just kind of enveloped into your QRS complex because you don't have a distinct atrial depolarization. You're getting stimulus to your AV node from other places. And so not every ventricular depolarization, not every QRS complex is coming after an atrial depolarization. So you have your P wave, but it's kind of blending into the QRS complex because you're getting multiple sites of input to your AV node. And it's usually right next to that AV node. Here's another one. And what I want to go back here just to highlight this, because you might have noticed this, is that in paroxysmal supraventricular tachycardia, because there is there's an electrocardiologic reason that I'm not going to go into. I don't really even understand it completely. But when you have PSVT, you can get this electrical alternans, which, remember, normally we see this most distinctively in cardiac tamponade. But this QRX complexes of varying intensities, alternating intensities. So PSVT, your P is being absorbed into your QRS complex. So it looks like you have no atrial depolarization. But you do. This is not atrial fibrillation. This is just you're having so many QRS complexes because you have ectopic stimulus to your AV node that your P wave is just kind of blending right in to your QRS complex. So in any patient that comes in and they have tachycardia, or they have chest pain, or they have palpitations, if they have risk factors for an MI, get cardiac enzymes. I mean, you're going to be getting an EKG anyway because they have palpitations, and EKG is always the best first step for a patient that appears to maybe be having an MI. But cardiac enzymes are also good to get in addition to that if this is really a patient with a risk factor for an MI. If this is a 27-year-old female who is perfectly healthy and comes in with palpitations, you don't need to get cardiac enzymes. But if this is a 62-year-old chain smoker, then definitely get cardiac enzymes because they're having palpitations and they're having chest pain. So how do we treat PSVT? How do we treat these paroxysms, these episodes of supraventricular tachycardia? Well, first off, we need to know, is this patient stable? If they are stable, if their blood pressure is fine, if they're awake and alert, then you can start with vagal maneuvers. And the most common vagal maneuver is the carotid massage. Now, the carotid massage is done because the carotid artery is right next to where the vagal nerve is. And remember that the vagal nerve gives, it will slow down the heart. You can also sink the patient's head in water or in cold water. That will stimulate the vagus nerve. it doesn't matter. Vagal maneuvers. So just know carotid massage is the most commonly used vagal maneuver, but there's lots of them. Different doctors will use different ones. So if the patient's stable, go ahead with vagal maneuvers. Now if the patient's unstable, so their blood pressure is low or they're unconscious, or the vagal maneuvers haven't worked, I don't know what length of time we can use the vagal maneuvers before we go on to using drugs. I'm sure there's varying opinions, but you're not responsible for that on the USMLE. If they're not responsive to vagal maneuvers or the patient is unstable, you're going to start an IV line and you're going to give them IV adenosine. And adenosine is not used for anything else, not for any other illness other than PSVT, for converting them out of PSVT and back into a normal sinus rhythm. So IV adenosine. You can also use IV calcium channel blockers, but IV adenosine is the best choice, in my opinion. If this is a patient who has frequent bouts of PSVT, you can maintain them on PO beta blockers. So have them on oral metoprolol, and that will reduce the frequency of these incidences. Cardioversion is a last line treatment, so after you've tried vagal maneuvers, you've tried adenosine, you've tried calcium channel blockers, you can do synchronized cardioversion. That's a last line treatment, but we try not to use that because one of the side effects of cardioversion, if it's 1 in 100 times that it might happen, is ventricular fibrillation, and that can cause death. So we try to use medical therapy first. Okay, so now let's talk about a different supraventricular tachycardia. Not paroxysmal supraventricular tachycardia, but a different kind of arrhythmia where you're getting an input to the AV node that's not the SA node. So in this case, you have multiple competing pacemaker sites. So not just one, you've got multiple all over, scattered around the atria. And these are feeding in electrical activity to the AV node. And so unlike the other SVTs, because you have multiple competing pacemaker sites, you're going to have lots of different P waves that look totally different from one another. And so that's going to be something that's going to distinguish this on EKG. So you'll have tachycardia. Usually it won't be as fast a tachycardia as you have in some of the other SVTs, but you'll have tachycardia. But what's unique here is you have distinct morphologies of P waves. And that's because you have electrical input sites at different points in the heart, and that's causing different looking P waves. Normally our P waves all look the same. Why? Because we normally get all our AV input from the SA node. But in these patients, they're getting input from multiple different sites at geometrically different places in the heart. And so the geography of their P waves are going to look different. They're going to have multiple different looking P waves. Now, multifocal atrial tachycardia is usually associated with COPD, and it's usually associated when they become hypoxic. And so that's going to be really important how we treat these patients. The symptoms, just like any tachycardia, is going to be palpitations, possibly dizziness, and shortness of breath. And we diagnose this like any arrhythmia on EKG. Anytime a patient has palpitations, and of course these are usually going to be older patients because older patients are the ones who tend to have COPD. Anytime you have a older patient with palpitations, EKG should always be your next step because what are you thinking? MI. So EKG should be your next step. And what you'll see is something like this. Now this is different from paroxysmal supraventricular tachycardia because in this case these waves look totally different. And so what you have here now are different looking P waves. So you have multiple different geometries of P waves. So you got this P wave here, and this P wave here looks like this, and this one looks like this. And so you've got multifocal atrial tachycardia. You have various looking, different looking P waves, and that's how you diagnose it on EKG. Here's another one. So this one's a little bit better because I like this one better because you can see that the heart rate is usually not that fast, not as fast as it is usually in PSVT. So you can see you do have your T waves here, but your P waves are clearly what are abnormal. So here's a T wave, here's a P wave here. It's kind of a little dotty looking thing, and here's a nice big peaked one. And here's, if you look down here at this long V5, you've got a small one and kind of this little tiny one that dips, and this one that's kind of peaked. So you've got different looking P waves, and that's multifocal atrial tachycardia. Once you've diagnosed this, here's another one. So you can pause it if you want to look at this one. Once you've diagnosed this, stabilize the patient if necessary, and the treatment for this is going to be to oxygenate the patient. Oxygenation is going to be what gets the patient out of MAT. So 100% oxygen by face mask if necessary. These COPD patients may need tracheal intubation, but 100% oxygen by face mask will be your next step after you've stabilized the patient if necessary. Wolff-Parkinson-White Syndrome is a congenital syndrome, and what this is it's also an SVT, but it's an accessory conduction site between the atria and the ventricles. Of course, multiple different sites are possible, but what sets Wolff-Parkinson-White Syndrome apart is a very, very, very distinctive feature on EKG, and also that this tends to be a disorder in pediatrics and young adults. So what you'll have in Wolff-Parkinson-White Syndrome is a patient that presents with tachycardia, palpitations, maybe syncope, and you'll do an EKG, and they'll have a wide QRS complex with a sloping, what's known as delta wave between Q and R. So this is what Wolff-Parkinson-White Syndrome is. Here you have this is normal. So here's your SA node, conducts to your AV node, goes down your bundle branches, and contracts the ventricles. Here's Wolff-Parkinson-White Syndrome. You have an SA node, it conducts through the atria, conducts through the to the AV node, goes down the bundle branches, but here now we have an accessory pathway. So this is different because in the other ones you have foci of input going into your AV node. Here you have an accessory pathway that's going from the ventricles back through the atria and then into your AV node and into the ventricles. And so this is Wolff-Parkinson-White Syndrome. And the accessory pathway can be in many different sites, so it's not always right here. So it shares some things with some of the other SVTs, but the accessory pathway from the ventricles to the AV node is what sets this apart. And so this is the characteristic delta wave, and this is pathognomonic for Wolff-Parkinson-White Syndrome. So if you can see here, you have QRS start. Here's your Q, here's your P wave, here's Q, and then R is right here, and you've got a slope here and a different slope here. So this wave here is a delta wave. So it's kind of a wider QRS complex. So here's another one. You can see it a little bit less distinctive because you can't. It's a little bit more zoomed out, but you can see it here. V2 is probably the best one you can see it. Here you can kind of see you got a smaller slope here, and then here's your larger slope. And your QRS complex, the only reason it's abnormal is because you're getting atrial depolarization at the same time you're having ventricular depolarization. So that's what's causing this delta wave, and that's Wolff-Parkinson-White Syndrome. So Wolff-Parkinson-White Syndrome, we will treat acutely symptomatic cases, and we basically treat it the same way that we'll treat PSVT. So I kind of lied. You can use IV adenosine for Wolff-Parkinson-White Syndrome too. So adenosine is fine. So vagal maneuvers, IV adenosine. We're basically going to treat this like PSVT. IV procainamide can also be used, but adenosine is the best medical therapy. And Wolff-Parkinson-White Syndrome is can be cured. So patients who have this frequently, they can have surgical management, and what you basically do is just ablate where that conduction, that accessory conduction pathway is. So you just go in with radio waves. You just kill off these nerves right here, and that would hopefully cure the Wolff-Parkinson-White Syndrome. Okay, so ventricular tachycardia. So up until now, we've been talking, with the exception of sinus tachycardia, up until now we've been talking about supraventricular tachycardia. So some kind of thing that caused tachycardia that was originating from above the ventricles, supraventricular. Some kind of foci from above the ventricles, or from the accessory pathway, which indirectly was above the ventricles because you're causing a new atrial depolarization. With ventricular tachycardia, you're getting depolarization of the ventricles from a site on the ventricles. So you can see why this would be really, 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 really bad, because you get depolarization of the ventricles, and then you excite this site, which causes depolarization of the ventricles, which excites itself again and causes depolarization of the ventricles, and now you're just having your ventricles contracting and contracting and contracting and contracting, and you're not going to get any blood into those ventricles because you're not getting any atrial depolarization. Your ventricles are just going nuts contracting, and they're not filling with enough blood to maintain a blood pressure, to maintain perfusion. And so V-tach, ventricular tachycardia, is a medical emergency. And what's even worse is that this can degenerate into ventricular fibrillation, in which you're not getting any kind of real ventricular depolarization at all. You're just kind of having ventricular flopping or vibrating. And so this is distinguished in that these patients usually have dramatic palpitations. A lot of times they're going to come in with syncope or severe chest pain. And so what you'll see on EKG, of course, any patient, again, palpitations, you're going to get an EKG, and what you'll see on EKG is tachycardia, and you'll have these really wide and different looking QRS waves. And you're not going to see any P waves or T waves because they're all absorbed into these QRS complexes. And these QRS complexes are wide because the ventricles keep repolarizing or keep depolarizing themselves. And so the whole axis of the heart is messed up, for lack of a better word, because the ventricles are just they're just stimulating themselves. There's no atrial input, there's no SA input, there's no AV input. Remember that SVTs, you're losing your SA input. That's why you're getting a tachycardia. With ventricular tachycardias, you're getting no SA input and no AV input. All you're getting is ventricular input. The ventricles are just stimulating themselves over and over and over again. So it's going to require, generally, this is going to require cardioversion, but you can try an IV medication that will usually be your first step, but usually you're going to have to go on to synchronize cardio for these patients. And so this is V-tach, and when you see this, you'll never forget it. So look at this. There's no P wave, there's no T wave. You just have these wide-looking things, which I guess you can call QRS complexes. And this is just the ventricles stimulating themselves over and over and over again. Here's another one. Here you can kind of see maybe what looks like it might be some kind of P wave, kind of trying to, you know, rear its poor little head right here. But unfortunately, this is V-tach because you're getting constant ventricular depolarization. The ventricles are just stimulating themselves, and again, this is less than 2 big blocks between QRS waves. So you're talking about 170, 180 beats per minute here. And here's another one. This one's even faster. This one here is like 200 beats per minute. So again, just QRS waves, wide QRS waves. That's what's important here. You have wide QRS waves in V-tach. Here's another one. Okay, so what do we do with a patient with V-tach? If they are stable, and by stable I mean their blood pressure is satisfactory, it's okay. If they're not crashing, then I mean, I shouldn't say that. If they're stable, if they have pulses, if they if they're not dying on you, they have the V-tach rhythm, but they're awake, they're alert. It's still an emergency, but you don't need to cardiovert them. We really try to shy away from cardioverting if we don't need to, because cardioversion can cause ventricular fibrillation. If they are stable, if they have a blood pressure, if they have a pulse, then we're going to give them IV amiodarone. And this is all done on an ACLS protocol. You should have your synchronized cardioverter, though, ready if you need to use it. So IV amiodarone is what we use for V-tach. Lidocaine and procainamide can also be used if refractory, but IV amiodarone is your first step in a V-tach patient that is stable. Now, if the patient is unconscious or you don't feel pulses, you're just going to jump right to immediate cardioversion. With or without sedation. I would probably say without sedation. Okay, so Torsade de Pointes. So this is also a medical emergency, and this is kind of just a subtype of VFib. Of a V-tach. Okay, I screwed this up here. This is V-tach of oscillating amplitude. So Torsade de Pointes presents the same way: palpitations, lightheadedness, syncope. But Torsade de Pointes is a special kind of V-tach in that it has a specific cause, and that's anything that prolongs the QT interval. So the QT interval is just your time in between where the ventricular depolarization starts and where the ventricular repolarization starts. So the most common cause is hypomagnesemia, so a low magnesium. But it can also be caused by genetics, so some patients are just born with a long QT syndrome. And then there are a lot of drugs that prolong the QT interval. I'll show you some of those that you should be aware of. And what's unique here is that, yes, you have an EKG that looks like V-tach, but you have an oscillating amplitude of your QRS waves. So again, this is diagnosed on EKG, and we treat this in a specific way because magnesium will usually bring the patient out of Torsade de Pointes. So, okay, look at V-tach here. See how that looks? Now look at Torsade de Pointes. See how this is oscillating? Going up and down and up and down. That's a specific kind of V-tach known as Torsade de Pointes. And these are some of the drugs that prolong the QT interval. There's so many of them. What I would try to do is just commit to memory that a lot of the psychiatric drugs prolong the QT intervals, and then a lot of the GI drugs prolong the QT intervals. You can't memorize all of these, and I don't know if the USMLE suspects you to memorize all of these. Lithium probably for the psychiatric component. The antipsychotics do. The TCAs, we rarely use these anymore. Macrolide antibiotics, you should know those, so azithromycin, erythromycin, clarithromycin, cisapride, which is used for gastroparesis and diabetics, and then ondansetron, which is an anti-vomiting drug. So again, here's Torsade de Pointes, and here it is on another EKG. Again, you can see very distinctively this oscillating nature of the V-tach, which makes it a specifically Torsade de Pointes as opposed to just regular V-tach. Here's another one. And another one. And we're just going to give these patients magnesium. So if they're stable, again, I should add, if they're stable, we're going to give them IV magnesium. If they're unstable, we're going to cardiovert them. That's basically the rule of thumb. If any patient is unstable with an EKG tachycardia, we're going to cardiovert them. So stable IV magnesium, and that's just because magnesium works at getting patients out of this specific kind of V-tach. But if they're unstable, we'll cardiovert them. Again, this is last ditch. Long term, if these patients continue to have Torsade de Pointes, and who I'm specifically talking about are patients with congenital long QT syndrome, what you can do is you can give them beta blockers, and you can give them implantable cardiac defibrillators, ICDs. So what those defibrillators do is they're implanted, and when they notice that the patient is going into Torsade de Pointes, they give they basically work as a little shocker, like your cardioverter, and shock the patient back into sinus rhythm. So Torsade de Pointes, remember the association with magnesium and the QT prolongation. So let's just recap here. So we had sinus tachycardia, which can be normal. Treat the underlying cause. The narrow QRS complex tachycardias, PSVT. We use vagal maneuvers, IV adenosine, cardioversion. Multifocal atrial tachycardia will have the various looking P waves, usually not as high a rate as in PSVT. This is associated with COPD or any hypoxic disorder. We treat these patients with oxygenation. Wide QRS complex tachycardias, Wolff-Parkinson-White Syndrome counts as one because you have that reentrant bundle. And so what you're getting is a wide QRS because you're getting a reentrance back from the ventricles to the atria. You'll have your delta wave on EKG. This is congenital. We will treat this the same way we treat PSVT. Vagal maneuvers, IV adenosine. We can also radioablate that reentrant pathway if we need to in the long term. We don't do that short term, obviously. So vagal maneuvers and IV adenosine. V-tach is an emergency. We give these patients IV amiodarone and definitely be ready to cardiovert these patients. And IV amiodarone will usually bring them out of their V-tach, but if we have to, we'll cardiovert them. We don't like to cardiovert them right away because that can cause V-fib. Torsade de Pointes is associated with a long QT interval or congenital long QT syndrome. We treat these patients if they're stable with IV Magsulf, but definitely be ready to cardiovert them, especially if they become unstable. In the long term, we can prevent them from going into Torsade de Pointes using beta blockers orally or implanting them with a implantable cardiac defibrillator. And that is it.